Thank you so much. Thank you very much for inviting me. As a lawyer, I feel a little bit out of place sitting with my medical colleagues at a conference like this. And I have actually very little technological background. So my role here is actually quite ambiguous to me. I'm sure it will be to you as we go through this presentation. Actually, the Madam Minister of Health, I think, mentioned the important role that lawyers will play in this technological age of advancement in healthcare when she said that we need healthcare professionals, politicians, vendors, IT professionals, international connections, and financing bodies, etc. I consider myself an important part of the etc. That she mentioned in the very beginning. Let me tell you the reason I am here, actually, is to say that MedStar Health, like many organizations within the U.S., has dealt with the issue of medical error. And I think even in this country you have recognized that internationally we have a responsibility in healthcare to begin to deal with the issue of reducing unnecessary injury that occurs to patients where those injuries can be avoided. I, however, come today not to tell you that we found a great solution that we can migrate internationally or even within our own country, but to say that we have an approach that we think is working successfully so far. It's in its beginning stages, and we think the approach is nothing more than the application of very hard work supported by technology to get the job done. Let me give you context, if I can, for what we are doing. MedStar Health, first of all, is a typical integrated healthcare delivery system within the United States. I think you know that we have formed ourselves into delivery systems for the most part around the country. I'm not sure necessarily that they have done much to evolve the process of healthcare, but they certainly have done much to define the way in which the business of healthcare is administered. MedStar is a not-for-profit community healthcare delivery system. It has 25 enterprises. 7 of them are hospitals. 6 of those are general med-surg hospitals with 1 specialty rehab hospital. We're a $2.5 billion annual revenue corporation, and we have a number of sites that are ambulatory care rehab centers beyond our hospitals. And more importantly, I guess, for this discussion is we have 4 obstetrical OB units within our 7 hospitals. We had 5, and that's important because as I go through this presentation and describe what we've done over the last couple of years, we made the decision to downsize our OB program because we realized that we had redundancy in the system. We could do better as a system with fewer units managed in a different way. I also want to mention for context that I'm here, I suppose, as lawyer because in our country we are experiencing a phenomenon that I hope never reaches your shores, which is the liability crisis that has become such a phenomenon within the United States. I really do think we have 2.5 lawyers for every single human being that lives in the United States, and any time we turn around, we're looking at legal issues that affect the way in which healthcare delivery and healthcare financing is accomplished. So with a vibrant medical malpractice climate in our country, and MedStar living within that climate, we find ourselves actually doing something we never envisioned doing, which is becoming an insurance company for medical liability. We have our own captive insurance company. It has $7 million worth of liability exposure, corporate assets, for any single claim that might come forward. We have 120 claims on average that are filed against MedStar facilities and employees each year. We maintain a portfolio on a going basis of about 200 open claims. So it is a very important part, unfortunately, of the business of healthcare within the United States. But I must put that in context with what we also know, which is that in 1999, the Institute of Medicine told us what we already knew, those of us who have been part of the industry, is that the incidence of avoidable medical error was outstandingly high and needed to be controlled. The Institute of Medicine used 2 core reports in its findings. One was done in Colorado, studying the healthcare delivery system there, and found that, and one in New York, studying the admission to New York hospitals over a year, done by the Harvard Group. And they found that somewhere between 44,000 and 98,000 patients in our country die each year as a result of medical injury and avoidable error. I don't think it makes any difference whether you buy the lower figure or the higher figure, or whether you divide both of them by 2 or 3 or 4. We're talking about lives that are lost and could be saved if we could find ways to reduce the amount of avoidable error that occurs in healthcare. By the way, I do not, as a lawyer, and I've been inside the business rather than outside the business all of my career, believe that this is the result of people who are careless or an industry that pays no attention to these issues. But healthcare is a very complex business, becoming more complex every day. It also is a business that's driven by human beings. Human beings are prone to error. So we must find a way to give our clinicians who are seeking so much to find ways to provide safe care, give them the technology and the tools they need to make sure that care can be delivered. Well, at MedStar Health, we approach this, let me skip over the slide and go actually to this one, which is just to show you an example of what's happened in terms of the impact of the Institute of Medicine and the public reporting of errors. Healthcare has now become, unfortunately, somewhat the brunt end of a joke regarding errors. If you can't read that, it says you chose a hospital with a high rate of medical errors. I bet you could kick yourself with the leg that's been transplanted to the middle of your chest. It may be somewhat humorous, but for me it was discouraging to see that show up in the Washington Post, because it meant we had now sunk to a level in an industry that had been considered and revered as one of the safest and most caring to be one that was no longer deserving of that status. In 2001 at MedStar, we began our effort, and we did it very simply. Any of you who might be interested or I'm sorry, aware of the anesthesia experience in our country knows that anesthesia, many years back now, went through a closed claim study looking at the liability issues that are associated with their practice and found a number of repeating phenomenon that, in fact, could be corrected to prevent injuries from occurring. We took the same approach with OB. We went back and looked at our own data for 10 years, and these are the actual malpractice claims that were filed against MedStar over that period of time. And we, too, found that in this study, we were able to identify, first of all, the prime service for attention as a first instance as we began this process. You can see that obstetrics, although it represents 4% of our business, was 16% of the frequency of claims that were filed against us during the 10-year period. This is a 5-year slice, but it's very similar to the findings over a 10-year period. And if we look at the cost of those liability claims over that 5-year period, they represented almost a third of the issues of liability that resulted in costs in our system. So clearly, again, it was a disproportionate loss leader for the purpose of looking at liability, and since this effort began with a focus on liability, we chose OB. As we dug into the data, we found some interesting things. We analyzed all of our OB cases and found that, to our surprise actually, that over 60%, 67% of the issues associated with those claims involved organ damage, principally brain damage, for infants that were being delivered. The nerve damage, 17%, is actually the brachial plexus injuries for the most part. And I said surprising. Actually, it was not surprising that this was the major cause of our liability exposure, but it was surprising to see that it was quite as high as it was. Even more surprising were the causes. As we dug into the issues, and by the way, when I say we, I'll explain as we go along that these were clinicians that were looking at the issues. Although these are legal cases, we use our clinical staff to help us understand the true etiology of the events that produced the kind of liability we were seeing. Particularly surprising was this issue, which was we found that in over 70% of the cases, the issues that were alleged, and in fact the issues that were demonstrated by our review, were issues of competencies. The biggest one being what seemed to be a very amorphous issue for us at first was clinical judgment. And if you think about it, obviously in all specialties, judgment is a very important part of the art and science of healthcare. What we found in this study was that issue of judgment simply represented those retrospective reviews of those cases where the judgments that were made at the time of the delivery were inconsistent with clinical best practice established at the time. Again, these are over a 10-year period. The practice changes over 10 years, and so we had to continue to make sure we were adjusting our view of those cases based on the science at the time. Also important in this slide is that we found that documentation was an important part of the exposure we had from a liability perspective. Obviously very important in terms of patient care, but many times we found that even when we did deliver good care and the outcome was not preventable, we had no documentation to support that finding. And the issue of supervision was primarily the issue of chain of command, and we have a great number of residents who provide care in our obstetrical programs and often left alone without the direct supervision of physicians. In 2001, we then formed a committee. That's what hospitals do in our country, is whenever there's a problem, we form a committee. We have that committee take on a charge, and we oftentimes lose sight of the fact that the committee is still functioning until years later when we might hear from them. We were very concerned this would be the same process, so we made sure that this committee was different. First of all, it was made up of only the leaders within our system in the OB area, the OB directors and the OB nursing chairs. And that was important because around the table we wanted decision makers, not those who had to go back home and get permission or ask whether or not they were going in the right direction, but those who were responsible for making the decisions regarding care. And their charge was very simple: to develop measurable, and we didn't know how to define measurable at the time, except we wanted to make sure that we could show that there was in fact by this effort a reduction in the cost and adverse outcomes associated with OB practice. We also wanted to make sure that we began throughout our system to adopt nationally accepted standards and also internal best practices. We found with 5 programs, we had 5 ways of delivering OB care within our own system. Multiply that by the number of OB programs across the country, and I am convinced that one of our issues is that where we can standardize, where we can use both technology and best practice and protocol to drive practice, we can do a better job if we're not so individualistic. The results so far, and I said through 04, we haven't measured all the results for 05 yet, although the liability results look very good. One thing we've got is a very much improved collaborative effort among the OB practitioners within our system. Not any longer 5, now 4 separate programs, but really one system-wide OB program that all seek to do the same for each of the patients that comes into our care. We've also identified patient care standards, particularly oxytocin or Pitocin standards. We found in our liability claims in OB, one of the biggest areas was that during those few hours when clinical decision-making has to be made as to whether to deliver a patient, deliver a child by C-section or by vaginal delivery, we oftentimes don't have the data available, and oftentimes we're using the stimulation of childbirth through the use of Pitocin in an inappropriate way, resulting in our going far too long, trying to do vaginal and natural delivery rather than doing a C-section. Important also, I can't report today, but we have funding from the Commonwealth Fund because I believe that the work that we're doing, as small as it might be in the scheme of things, will demonstrate that the application of clinically driven best practice protocol will both produce better safety for patients and reduce costs. And I've had some discussion with some of my colleagues about the issue of whether or not cost can be affected. And through this Commonwealth study, we intend to show, at least our hypothesis is, that those costs can be driven down as a result of using these clinical protocols. However, after we developed the protocols, we realized that they're of no value. We were quite proud of the fact that in 2001 we started the project. In 2002 fall, we had completed a good number of the important protocols. We had done the typical job that healthcare institutions do by in-servicing as many of the house offices as we could round up, all the nursing staff, because they are captured audiences for us. Some of them sleep during the in-service, but at least they're present. And as many of the medical staff as we possibly could find who would be there to go through the protocols with us to make sure that they actually could be then used. Proud, except in February of 2002, a mere 4 or 5 months after the introduction of these protocols, we had a disastrous outcome at one of the 4 OB hospitals by a practitioner who had been, in fact, through the training, who knew the protocols, but in fact ignored the protocols during the delivery of a child, or at least wasn't aware of the protocols during the delivery, and made decisions that resulted in a disastrous outcome. That case resulted in a $4 million settlement. We settled that case very quickly. One of the nice things about having done the work we did, we in our own institution knew the standards that we held ourselves to. So in measuring retrospectively this case against those standards, we had, in our opinion, no defense for this liability claim. Although being the good lawyer that I'm asked to be, I went out and found 3 experts to review the case. One of them is the patron saint of OB lost causes, somebody who will find no matter what we did, we did the right thing, and brought him in to serve as an expert, at least so he had something to say during the settlement discussions. The two other experts we brought in were very well renowned, and they actually indicated to us, although they would be willing to give us an opinion, they would be unwilling to serve on our behalf in defending this case because the care had been so beyond the standard. Settling that case for $4 million got the attention of our group once again to focus, and we decided what we really need to do is find technology to help reinforce. Again, I'm the non-technical person, so my solution was very simple. Let's find a way that we can embed the chip within the minds of all of our staff with the protocols coded into the chip, so that never again will they not remember what the protocols are or be confused by protocol that are not available to them at the time. On the shelf, they're of no value. In their brains, they would be of value. And with that simplistic approach, I went out and looked for a technology solution. And in fact, I found something. I'm not here to tout a product. I'm here to talk about a process and an approach. But we did find a product called IPROB, Intelligent Patient Record for Obstetrics. It's produced by a company called E&C Medical. It is the only product of its kind that I found at the time in 2002, which is actually a protocol-driven, intelligent-based physician and nurse documentation and order entry system. What this system does is provide real-time alerts to our healthcare providers so that they actually do have that chip memory of protocol before them on the computer screen as they're entering orders for the patient. And it gives us the ability to go back into the database that's developed by this system to see how our clinicians are doing in comporting with the protocols that we've established and they've accepted. Simplest way to describe this, I suppose, is with this slide. On the right-hand side, we have all the unique patient information, the patient's age, their gestational age, the weight, whether they have blood work back from the laboratories or results from the fetal monitoring tracings that are being read. All of the unique patient information that a clinician uses in making decisions about a patient's delivery. At the bottom, we have our guidelines, protocols, and the expertise that we've decided to make available to our staff. And as they enter records, or as nursing staff puts documentation into the inference engine, what happens at that point is that the computer actually accesses both the unique patient identifiable information as well as the protocol, and if an order is entered that's inconsistent with the protocol, the system alerts the clinician. It doesn't stop the clinician from doing what they have chosen to do, but it tells the clinician at this point that might not be the right choice, given the fact that it's inconsistent with your own protocol. We found so far, and our Commonwealth study, I hope, will develop more of this data for us, is that as a result of having that chip now embedded in the computer in front of them, as they go through the process over and over again and those protocols are reinforced, we actually find them using the flags and the alerts far less frequently because they become more embedded in their practice, and that just makes sense. Over time, we'd hope that, therefore, the clinicians will really understand or be able to access in their own mind the protocols as a result of having used them over and over again. But if ever they forget, as one of our clinicians said, it's like a computer angel on my shoulder at 2 o'clock in the morning, reminding me of the protocol that I should be reminded of. In the few minutes I have left, I also want to talk about monetization of this kind of technology and patient safety. I am convinced that, at least in our country, we have so few dollars that are available to drive this process to accomplish the goals that President Bush and our leaders at every level in healthcare are striving to achieve, and that is the computerization of the healthcare system. We are so focused on the moment, and America, as you know, is a country that's focused on the moment more often than it should be, seldom looking strategically very far ahead. In healthcare, that's even more true. We, in our nonprofit status at MedStar, are struggling every single year to make sure that we make enough money and spend less of it so that we can actually continue to be in business providing the services we provide. How do we then find money to be able to use to advance this technology? One thing we've done at MedStar is that we decided that since liability was a key issue for us, and I'm paying $30 million a year into my self-insurance program, if we can change the profile in the future for medical liability in OB by using this new technology and using the protocol, it should cost me less money in the future to fund my liability program. However, the way that liability programs get funded is based on your historical data, not on the future promise that you have of reduction in liability. Actuaries, as you know, drive their vehicles not by looking through the front windshield, but looking through the rear view mirror. All they see is the past. They have no interest whatsoever in the present and the future. So we got our actuary into the process with us, and we said, let me take that $4 million case I mentioned. We fed that $4 million case as though it were occurring in real time, simulated it through the IPROB. Every single instance in which the retrospective review had identified areas where we deviated from national standards of practice, the system flagged an alert saying, are you sure you want to go there? Are you sure you don't want to change your course? Are you sure you're doing the right thing? Our 3 clinician experts who are hired and were going to work and working for us said we could justify a lot of the decisions that were made up to a certain point. It happened to be 1 o'clock in the morning that morning. At that point, there's nothing that can be done to explain what took place other than deviation from the standard that is not acceptable, not explicable. Our system said the same thing, IPROB. Literally at that point, red flags were all over the place. And I realized anyway, that from a liability perspective, this was a terribly exciting tool. Rather than doing it retrospectively, which is what I always get to do when these cases come to my desk, we actually, with our clinicians, could do this prospectively. So I took our actuary and I said, that $4 million claim, had we had IPROB, I'm convinced never would have occurred. I don't expect you to give me full credit for that $4 million disappearing from my history, but what if we simulated all the other liability cases we've had over the last 10 years, and we find that some of them anyway would have been similarly affected? Would you at least consider giving us some prospective credit for what now would be a change in the view of history based on some assumptions? And the actuary didn't say anything except scratch his head and ask us to do the work, and then he'd tell us. We went away, and our clinicians, in fact, did what I just described. They came back and said, in our major liability cases over 10 years, a good number of them would not have been any difference. They were technical issues where we had brachial plexus injuries, for example, that were the issue of manual manipulation and process rather than protocol. But they said in a number of cases, there's no question, like the $4 million case, it should never, would never have occurred with the kind of alerts being given to the clinician staff. As a result, we changed our retrospective profile of losses for OB, fed that information to our actuary who said, all right, if that is true, then as of today, you can take a $2 million credit against your self-funding for your liability program. And we did, and we used that $2 million to actually buy the solution, buy the technology, fund the license and the technology hardware needed to put the solution in place. All I'm suggesting is that we need to find creative ways in which we can find monies that otherwise would be wasted on the old paradigm in order to afford the technology and the solutions we need for the new paradigm. You can't use liability in every instance, I realize that. But I'm sure out there are those who can help us think through the process that we can use to find those monies that otherwise would be wasted and make them a valuable use. Bottom line is that now with this system we can provide the opportunity to our clinicians to do the right thing in every instance. It's up to them to do it. Let me just show you very quickly the results from a financial perspective and from a claims perspective. I don't know how well you can read the text, but during the period of time before we began this project in 2001, we experienced a fairly significant rate of loss, as I told you before, in OB. After 2001, when the implementation and the development of protocol began, we saw an immediate decrease. I must say the first year, I think it was simply the Hawthorne effect. We spotlighted OB. Everyone in OB knew that we were focusing on that issue, and therefore I expected we got a great deal of return from our effort. In 2002, 2003, I think a good deal of that had to do with the fact that we had been implementing these protocols, and developing new ones to address issues as they were being identified. 2004 and in 2005, and I don't have 2005 up, but if I did, right now, I'm a little bit afraid to say that it would say 0-0. We have no major claims that involve OB in 2005, and we've identified no events that are going to result in liability in 2005. I don't believe that this data is going to stay static as it is now. Adverse development may occur in the prior years, going back to 98. The OB tail for liability is long. Adverse development may well occur from 2002 going forward, but what we see right now at this stage is 1/3 of the numbers of claims each year on average, and 1/3 of the costs associated with those liabilities on each year on average. And even if that does deteriorate somewhat, I'm satisfied that our goal in the beginning, which is to show measurable reduction in the number and the cost of claims, is being achieved. I'll also say, however, I think this is embryonic, and I think that we need to continue this effort for many, many years and study it very carefully to make sure that we don't lose sight of the fact that monitoring this data is extremely important. Keys to success, very quickly if I can. At MedStar, and I guess that's all I really can speak to, is the first part of our success was having a burning platform. I think we all have a burning platform. Ours was liability. I used it as a tool for accomplishing what I want to accomplish. I'm tired of working on the retrospective analysis of claims that have already occurred. I'd much rather spend my time and the expertise that I do have focused on preventing those so they don't have to worry about defending claims and doing the work on the liability side. And that burning platform was also, I must say, driven by the monies that were involved in liability. When we spend $30 million a year, I at least get a little attention from the board if we start talking about reducing that. We had a corporate leadership that's committed to a system-wide patient safety improvement. I think almost any organization in our country anyway has to be able to say that. I hope that most organizations actually mean it. And it really is important that, that leadership come from the top and not from those who are on the field. We work on the basis of having a very strong board at MedStar, a community-based board. And we were pleased that our board, when presented the data for the 10 years of analysis where we showed them how bad we had been, were able to work with us in identifying a very positive approach to going forward. But I must say that what we wanted from them was a sense of expectancy, a sense that we had to accomplish, and a sense of demand on us. I needed that, so when I went to the clinicians and explained the fact that this was not an opportunity for cooperation, this was a mandate, we got much different results than we might have gotten in the past when we had very little support from the board and the folks at top. The personal involvement of the clinical decision makers, I mentioned the OB leadership and the OB nursing leadership were involved. Without them, this is not really a valuable exercise as far as I'm concerned. We'll achieve nothing more than getting those who already know the change has to be made to be making recommendations to those who actually make the decisions. I want those who make the decisions to be at the table. And a clear mandate, as I mentioned already, with no opt-out. So the point of my presentation is that I think that the issue of error prevention, quality of care is something that is within our control. And we can complain, as we do in our country, about the tort system and the fact that liability claims come fast and furiously. But I also can remind our medical staff that according to the data, only 4% of the claims that actually could be brought through the U.S. liability system in medical malpractice are actually brought. So we really are only looking at the tip of the iceberg in terms of the exposure we have. So there is a very clear need for us to get a handle on this ourselves before somebody makes the decision to put that kind of pressure on us. And through those controls, I think we can achieve the three goals that I mentioned: better outcomes, most important; higher quality of care, most important; and loss prevention, at least as an add-on. Thank you very much.